Hello, everybody. Welcome to another session of CPS on a special Tuesday. We have our team here with us today, and I'm glad that we're going to be co-discussing, or I'm going to be co-discussing with Hans today. So I'm going to mute for a second and let Hans introduce himself. And then before we get underway, I'm going to ask if anybody has a case. If they're willing to present, please step on up and bring your case and see what we can do. Hans?
Yes, good evening. I'm a recent graduate from Russell University, and yes, I did not go for the match in the US because I couldn't. Maybe now a match in Canada, I'm not sure. It's still in the run over there. We're a little bit slower than the US.
Always great to have you here, Hans. And like I was mentioning before, I've been very impressed with your growth on CPS, and I'm always looking at your comments in the chat, and you're beginning quite a few of the diagnosis on these cases, or close to the diagnosis. So it looks like Mario is as a case, and he's kindly volunteered to present a case. Are you able to unmute your mic, Mario, and introduce yourself for a bit?
You hear me?
Absolutely. How are you?
Yeah. Hi everyone. My name is Mario. I haven't logged in for a while now. I think it's over a year. So excited to be back. I have a very interesting case. I have a PowerPoint presentation, but I cannot present it, but I can present some images. I don't know if that's okay.
Yeah, that absolutely. Any way you'd like to run it, yeah, we'll go along with whatever method you would like to present. But I'll make you a co-host so that way you can display your images. All right, are we ready, team? Deploy the whiteboard, and Mario, the first aliquot, if you may.
Yes. So this is a case I saw a while back, but this is a 58-year-old female that presented with 15 days of constipation.
All right, Hans, you want to take a first stab at that? Oh, Hans, I think
you're muted.
Sorry, my apologies. 15 days of constipation. At first, I was thinking about the digestive tract. Is there not necessarily obstruction, because she still must have some kind of bowel movement, which probably allows some flatus, but constipation, has it to do with her diet? Is it related to IBD? Or 15 days, is there any metabolic problem? We once had a problem where we had hypercalcemia, so this would be a possibility explaining constipation. And yes, anything that would slow down her digestive tract, like an autonomic dysfunction, but at this point, I'm not certain about this one. It's just a vague hypothesis. And I leave the mic to Ravi now.
Yeah, absolutely wonderful start there with the possible causes. It's kind of, I'm going to have to try and take what you presented there and maybe make a scaffold or try and make it more visible to the audience. So with constipation of 15 days, so it's something that's subacute, so quite recent. I'm also interested in the next aliquot to see if there's anything there that could have resulted in this, namely, like Hans had mentioned, any medications that could be suspected. Are there any agents that could have contributed to this? The bowel functions in a sort of a independent environment, so it has its own milieu of electrolytes. So electrolytes are very important. If there's any loss of any of the electrolytes, you can end up having conditions like an ileus. Could there also be something going on with the bowel? If I'm going to attempt to answer it earlier on, an anatomical approach may be very helpful. So the bowels, is this something that is related to the small bowel, large bowel? Is there a change in the bowel habits recently, or even before the onslaught of constipation? And are there any associated signs or symptoms? So is this something more than the bowel? Is it within the bowel, or is it outside the bowel? So some sort of a systemic condition. So at this point, I'm going to leave it relatively brief. I don't want to invest too much cognitive energy in discussion, since there could be so many different possibilities. But again, it's gonna be difficult to sort of make our thinking visible with just the first complaint. But back to you, Mario.
Okay, so I'm gonna jump just one bit for a while to the past medical history, because it's the way we approach the case. So this patient had a recent diagnosis of multiple myeloma. He had just finished his fourth cycle of VRD, so that would be bortezomib, lenalidomide, and dexamethasone. And she was deemed as a fit patient, so she was about to enter the auto hematopoietic stem cell transplant pathway. So she was on continuous therapy with lenalidomide, also called Revlimid. She had one of the side effects of she presented after taking this lenalidomide. She did have constipation for a while, but she did report that in the last 15 days, the severity of this constipation was significantly different. I don't know if you want me to stop there, or I can continue with the HPI.
Yeah, I think we can continue.
Okay, so as I said, the time course was around 15 days of an insidious onset and a progressive course. This began after being discharged from the last hospitalization after finishing its last chemotherapy cycle. And as I said, the constipation, although it was a common thing during his treatment for his multiple myeloma, she did have more severe than usual. She was on bisacodyl. I'm not sure if I'm pronouncing it correctly. Laxative that usually did help her, but this time it wasn't effective. And so five days before admission, she noticed abdominal distension. 4 days before, she started having like some colicky type abdominal pain, and that's why she came to the ED with these complaints.
That's a great point to stop at. I'm going to allow Hans to take a stab at this, and I'll follow up after. Hans?
Now, she already received 5 cycles of her treatment, which is bortezomib, Revlimid, the lenalidomide, and D, I think, for dexamethasone. She should actually be in remission as far as her multiple myeloma is concerned. And she also received, I think, for consolidation, they call it, her chemo to get her ready for the stem cell transplant, probably for harvesting her own stem cells first. So the reason for her constipation, which has deteriorated, I'm inclined to put calcium a little bit lower, although I don't want to rule it out. But now I ask myself, is there a possibility of any side effects of those drugs that I'm not aware of at this point that could really cause her the constipation? And another point could be her gut microbiome. The intestinal microbiome might be completely upside down with this treatment. So this might have changed her bowel movements completely, I suppose, as a possible explanation for this one. Another possibility would be, and I'm not sure about those drugs, how far they could cause any autonomic dysfunction. I think with thalidomide and bortezomib, I've read something remotely that they can cause a polyneuropathy, something like a loss of sensation. So it is maybe possible that this might affect the autonomous system as well, including the digestive system. But that is a vague assumption, which I cannot prove at this point, but it is a possibility with those medications.
Great elaboration there, Hans. I really like that. You really started thinking about medications, and interestingly, if I remember, medications are probably the most common cause of constipation. So I think putting an emphasis on medications here this early, I think is great. I'm also not too sure about the meds, and I love the physiological breakdown of the possibility of these meds causing slow transit time and autonomic dysfunction. That could be a cause. And what really is concerning here, if we just take the age as well, or even let me backtrack, what are the common causes we mentioned? Number one, likely medications are a cause there. And again, I'm not sure about these medications, but the abdominal distension makes me worried if there's a mechanical obstruction. So I put mechanical obstruction possibly high up in the list as well. We talked about systemic illnesses. There is an illness here that's questionable, the multiple myeloma, and then just to the side, electrolyte abnormalities. People have mentioned calcium. And then the physiological abnormalities that Hans had sort of ventured into. So altered physiological states could also be a cause of constipation. And then the last thing is psychiatric conditions. So that could also be a cause, but here it's a diagnosis of exclusion. I wouldn't go into it because we have quite a complex medical history, and we must actually wade through those before even considering psychosocial issues as a cause of constipation. The alarm symptoms, I always like to think about what's really going to make me worry about the patient. First is the age. Is there history of colon cancer? Has this patient had a colonoscopy? So malignancy does come into consideration here. So that's high up on the list as well. And again, you have abdominal distension. I'm thinking there's mechanical obstruction. What can cause a mechanical obstruction? Something intrinsic to the bowel, which could be malignancy. Something extra, also gastroenterological, maybe a mass compressing on the bowel as well. So I'm sort of worried about that, and also wondering if there's any sort of bleeding into the bowel too. So any hematochezia that could indicate that there could be something nefarious at play here. It will be interesting to get the labs and see if there's any anemia that could also signal maybe a malignancy. And also in the past medical history, if there's been any colonoscopy. So I'll stop there. And any other thoughts, Hans, before we go on to the next aliquot?
Yes, thanks for the good thoughts. I'm just trying to anticipate a little bit her labs, because she's on chemo and on those cycles for her treatment. And of course, she has a multiple myeloma. So I expect the HB to be very low, maybe around 7 or 8. The WBC probably normal, and platelet could be low as well, but that's just an anticipation. So anemia, she might very well be anemic. And then, yeah, colon cancer is really a very good thought. Maybe she should have received colonoscopy prior to starting all these treatments, because we never know when she develops diarrhea or bleeding from the bowel, whether it's from the treatment or whether it is from another malignancy. Otherwise, I'm just anticipating the labs and the physical exams.
It was interesting. I was looking through your comments, and actually, Hans, you had made a great comment about steroids. And now I don't know the duration of the steroid dose that the patients had, but what can long-standing steroids do in the GI tract? So namely ulcers. They can pretty much produce ulcers. They can also suppress any sort of inflammation. So I was wondering if this patient has any manifestation of abdominal pain. Could there be a colitis? Something that could be very painful. Constipation usually can be very painful. I've had patients, if I look back on many cases that I had, and a lot of patients complain of pain, but steroids can suppress inflammation and can actually suppress very severe forms of peritonitis, any sort of gastroenterological perforation. So you wouldn't get that usual sort of abdominal catastrophe being manifested. So we got to be cautious with the abdominal exam if it's not too terrible or doesn't correlate with the severity of this patient's presentation. The vital signs may be helpful, but again, steroids may actually suppress some of the immunologic response that you tend to get with these, with severe cases of abdominal catastrophe. I'm having trouble saying the word catastrophic abdominal events. Back to you, Mario.
Yeah, so great discussion. In terms of family history, social history, health-related behaviors, there was non-contributory, no alarm signs. It was no known allergies. So let's go to the physical exam. In terms of vitals, his BP was 120/70, heart rate 80, respiratory rate 18, satting 98%. On room air, 36.4 Celsius was his temperature. That's normal, afebrile. Give me 1 second, please. In terms of his general appearance, he looked like a normal appearance. He didn't look cachectic or in extremis. Skin was warm. There was no jaundice, no cyanosis. There's mild, how to say, paleness. I think mildly pale. Heart was normal. Heart rate was regular, rhythmic, no rubs or gallops. On lungs, there was decreased breath. Lung sounds on both bases. There was no wheezing or no rails. On the abdominal exam, the abdomen was distended. It was bland, so there was no rebound tenderness or rigidity, but there was some tenderness to mild tenderness to diffuse palpation and to superficial palpation and also deep palpation. There was no visceromegaly noted, no ascites either. Besides that, in terms of his musculoskeletal exam, range of motions were preserved, no synovitis. And in the neurological exam, he was alert and oriented ×3. There were no focal deficits. Reflexes were 2+ in all 4 extremities. There was Babinski sign was absent. There were no there weren't sensory symptoms. There wasn't a sensory nerve, but he did endorse paresthesias in both lower extremities.
Okay, great, Mario. That's a very good physical exam there. I really appreciate it. I really do enjoy learning and teaching physical exams, and this really is helpful in trying to figure out what may be going on with the patient, especially with a patient that may have you want to rule out at least an emergency like an acute abdomen. So what I'll do, Hans, I'll tackle the vital signs there to see if that helps or not, but just sort of walking backwards, employing some metacognition. Where are we at this juncture? So and this could be also forming our problem representation. So 55-year-old female with 15 days of constipation, and then what's traveling with that is abdominal distension, and then there is pain, colicky abdominal pain, in spite of possible immunosuppression from the steroids. And there's a recent diagnosis of multiple myeloma, which we also have to then include in our thoughts on what that could potentially do to result in this presentation. So calcium is one component that I would take out of that, and definitely put that on the table and consider that. And that will come out with labs. So labs will be very helpful. And then also the patient is in an immunocompromised state. Somebody also mentioned possible infection. So we also must put that on the table as a possibility. But at this point, it's making the cognitive load very, very heavy at this point. So there's a lot that we could branch off and just elaborate and just keep going down a deep rabbit hole. But I'm going to sort of keep it superficial. Now we got to the exam, and the vital signs, I'm going to say, are relatively not active, like not very, very abnormal there. So in case, say the patient was very anemic, maybe hypotension would be there. Patient is severely volume depleted. The heart rate may be up, and also the blood pressure may be down. The patient, say the patient has massive ascites or a large abdomen pushing the diaphragm up into the chest, they may be hypoxemic. And there's also no fever there to entertain a possibility of infection, although that still could be a play here because the patient is on immunosuppressants, so we can't completely exclude that. So where are we still? I think we still have tabled a number of possibilities, but then I'm going to ask Hans to break apart the exam, and then I'll just come in behind you and then sort of give you my thoughts as well. Hans?
The two things that stand out on the exam are the pulmonary exam, the decrease in breath sounds in both bases, but no rails. And then we have the abdomen distended, no tenderness, no ascites, but some tenderness diffusely is what was mentioned across the entire abdomen, and the colicky pain. So now looking at the pulmonary, decreased breath sounds, why is there atelectasis, or is there an infection? Because there are no breath sounds, we probably might not even notice the rales. And that could be from an immunocompromised state, which she probably is in right now. And then the abdomen, the distended, and the colicky situation, it was mentioned before, kind of indicates the possibility for an impaction. So is there maybe an X-ray of the abdomen might already show it? Is there obstruction because of an impacted feces? Now, the reason for this, I do not know yet. It could be calcium or anything else going on with her medication and her present situation. So the labs are going to be very interesting now.
Absolutely there. I love what you've done to break apart the exam. So yeah, this just adding to your discussion of the pulmonary exam, the absent breath sounds in both bases, what does that mean? It could be a number of possibilities. You could have anything from just atelectasis, as I kind of mentioned, that you could have a severely distended abdomen pushing the diaphragm up, and you have bilateral low lobe atelectasis. You could also have pleural effusions bilaterally, so there could be some very sinister process like a malignancy, and that could result with movement of inflammation, malignant cells into the pleural space bilaterally. The pleural space could also be occupied by just fluid or cells or pus, although namely I'm not getting a strong feeling of an infectious process here, but still we're going to keep that on the table and maybe bring that out if we get more information, maybe in the hematology with the WBC. And a maneuver that would be helpful here, of course, I'm going to mention POCUS, but eliciting dullness. So dullness to percussion with the pulmonary exam may help. Maybe decreased breath sounds. I doubt pneumonia. Pneumonia you will get anywhere from crackles, rhonchi, to changes in speech with agophony. Tactile fremitus also may be increased. If there is a pleural effusion, you may have decreased tactile fremitus. Now, moving on to the abdominal exam, you have distension, no tenderness, though. That's interesting, although the patient was having colicky abdominal pain, but that may just be the bowels trying to move the stool, if there is stool in the bowel and is stationary. The rush or peristalsis may induce some pain there. And there's also going to be some intestinal gas there, although I'm going to ask Mario afterwards when he unmutes if there was any passage of gas. That would be important to know as well. And then bowel sounds, that's also important to know. I would like to know if we're dealing with a silent bowel or silent abdomen, that would be critical. and that could be quite an ominous finding. But if we have hyperperistalsis, so this rushing of contractions, that could indicate that they could be impacted, maybe impacted stool or mass or malignancy there. The paresthesias in lower extremities, maybe we're dealing with a neuropathy. Is that related to any sort of vitamin electrolyte abnormality, or is it due to the medications? I'm not quite sure, but I'm going to keep that on the table too. At this point, nothing is crossing my mind that I can really connect, but it is kind of interesting. How can you have paresthesia? What can develop? I know iron deficiency can cause restless legs. No history of alcohol use, any vitamin deficiency that could cause it. At this point, I'm just going to leave it there, but definitely is an interesting thought. If anybody has any ideas, please elaborate in the chat and we'll discuss it. And skin, I think you said also that the patient was kind of pale. So that to me, especially if there's any conjunctiva pallor, or even like Reza mentions, palmar crease pallor could allude to anemia, and anemia would maybe correlate with intestinal malignancy. That was discussed in the initial portion of the discussion. So I'm going to stop there and see if Mario, if there's any abdominal sounds that you can tell us in the exam.
Yeah, great discussion. So to answer Ravi's question, I think you asked if he had passed any like flatus, like gas. So that was a big teaching point for me, because I forgot to ask it. And in fact, the patient hadn't passed any flatus in the last for 3 to 4 days. She couldn't specify. So no, she couldn't eliminate gases for around 3 to 4 days. I don't know if that answers the question. Okay, so let's jump to the labs. So WBC 5,000 with a normal differential. Hemoglobin was 10 with I think it was 86 of mean corpuscular volume. Platelets 220 to 220,000, so a normal CBC. Sodium was 139. Potassium 4.2. Chloride 102. Bicarb 24. BUN was 22 and a creatinine of 0.8. I don't remember the glucose, but I think it was normal. And the calcium was 9, so a normal calcium. I don't remember the phosphorus, and the MAC I think was also normal. AST and ALT were normal. I think it was 20 and 25 each. Alk-Phos was 110. A total Billy of 1.8, and albumin of 3.2. So if it's okay, I would like to show the abdominal X-ray, if that's okay. Let's see if,
okay, go ahead. We can discuss the labs and the imaging then after. But I was going to say, yeah, imaging is going to be a great help, if anything.
So, can you see are you seeing the image? Okay, so on the left side of the screen, it's like a standing X-ray. On the left, I'm sorry, on the right, it's decubitus, so laying, no.
Hans, is there anything you want to maybe describe? Anything you see on there?
I mean, I'm strongly inclined to say that we have a situation where we have a total obstruction due to probably an impacted feces in the bowel, in the large bowel as it looks. And this might be present against the diaphragm as well. And this could explain, I think Marion said, we had no flatus for the last few days as well. So that would be almost like an emergency where we have to interfere in one way or another to make this thing go out.
Absolutely right there. I got very concerned when Mario had mentioned that there's any bowel gas that's been passed by the patient. And usually when you have constipation, you do have stool sitting there. Even if the patient's not taking in stuff, there's always going to be a daily production of some stool from bile, from cellular debris. So whatever is being excluded from the bowel. And with the number of bacteria, it's interesting that we have about 1 trillion bacteria sitting in the gut that helps our intestinal flora, that helps with immunological function, also with digestion, that they do emit gas. So and that gas developing or just not being expelled will produce such a X-ray as like this. And you're very, very correct in saying that this is a large bowel. As you see the haustra being outlined there, and there's a lot of gas there. I can imagine this being very, very painful. So on the left there, we see the standing, and you see air fluid levels there. And then with lying, you do see the air fluid levels gone. I don't see a whole lot of just a granularity which would indicate hard stool. So it's kind of interesting. Maybe there is just liquid stool that's present there. And we're not seeing any air in the rectum. So if you look around the pelvis, we're just seeing a pacification. So lack of air, which is if we talk about the dark appearance in the bowels, that's air. We're not seeing any of that. So the obstruction is maybe down. We're seeing the transverse. We're seeing the descending. So somewhere around the descending, somewhere there on the left side, if I'm not mistaken. But this is very concerning, and we'll see. I'm very interested now in seeing a CAT scan if Mario has one. But I think let's take a glance at the labs. I think there were some very interesting labs that we can pick apart. Hans, you want to take a try at the labs, and then I'll back you up.
The labs, to me at least, very surprisingly, they look normal. Her hemoglobin is slightly low. That was to be expected from her disease and the treatment, but everything looks really perfect there. We have a normal calcium. We have normal liver values and an albumin of 3.2, which is still quite close to normal for 4, which is the normal range. So I don't see any problems in the labs, but I'm just wondering what might have caused either the peristalsis of her intestinal system to stop, or what else is going on.
Yeah, you're right. Actually, yeah, there's quite a bit of data there, but yeah, overall, the theme of the labs is it really doesn't help us move anywhere. We're still sort of entertaining all these different. So our sequence has led to a number of different possibilities, which are kind of, I'm imagining putting all these thoughts on the table that's in front of me, and then seeing which one is more attractive. I'm not going to force any one of these diagnoses. May tend to do if any of you are on student VMR, we are forcing Sappho into a patient with rash on the palms and the feet, vesicular lesions with arthralgias and joint pain. That was a great case by Jane on Sunday. So in this case, I'm going to be cautious at this point, not trying to force one of these diagnoses. But what we do have here, though, with the exam and the imaging is very powerful. We do have a potential abdominal emergency. I'm actually not seeing anything within the bowel that's obstructing. So maybe something functional that Hans had mentioned, something that is physiologically impairing the bowel transit, the ability of the bowel to transit the stool through. And again, I'm not seeing a lot of hard stool in the imaging, but a CT may be helpful if you have one, Mario.
So yeah, great discussion. I do have a CT, but it's not from where you think it is. So sometimes diseases take time to manifest themselves. So I'm going to take you through this patient's hospital course. So as you said, this was concerning for an intestinal obstruction. We weren't sure if it was a mechanical or a functional obstruction. General surgery was called, and they deemed the patient did not meet criteria for a surgical abdomen and didn't feel he needed to go to the OR. That was day 1. On day 3, on the morning they called us, and the patient reported that she had difficulty with urination. No pain, no dysuria, just she couldn't pee. So we did an intermittent catheterization with a Foley, and she wouldn't pass the test, so we had to put a permanent Foley on. And on that same day, we were called again to the patient's room because the patient reported she had weakness in her lower extremity, and on the physical exam, she had 3 out of 4 reflexes on the lower extremities. Babinski was positive bilaterally, and strength was 3 out of 5 on the right side and 2 out of 5 on the left side. So what, do you want me to stop there?
Yeah, I think you've given us a lot of interesting developments. I'm gonna have Hans take a stab at it, and then I'll come in behind you and then tell you what I'm thinking.
Yes, I mean, we might probably need a CT scan of her spine, and it was already mentioned in the chat. This could be somebody mentioned cord compression. So the vertebral column, the skeleton there might be very fragile, and she might have incurred some kind of a fracture because of the multiple myeloma causing those punched out excavations in the skeleton. So it looks almost like a cauda equina symptom, with her becoming incontinent and the bowel obstruction, and now the paralysis in the lower extremity and the loss of reflexes as well.
Absolutely. I think that the chat is pretty much on fire with possibilities. So going through, the labs didn't really help us there. I think we had some great thoughts. So we're trying to link it to the multiple myeloma. The hypercalcemia theory is sort of, we have to jettison at this point. But now with this elaboration, I'm thinking back, could I have caught this early if we think this is likely the diagnosis we're going to commit to? And I'm thinking this paresthesia, which I was sort of perplexed about. Remember, I was thinking about it. How can I link it to this? I was having some difficulty, and very, very difficult sometimes to visualize your thinking on some of these exercises, but we try to do the best we can. But now I think we have a much more clear picture of how we can bring it in. So there definitely is, Hans in the chat had mentioned this cord compression or spinal cord association, definitely is something that can explain all of these. I will lean back on, so we have different kinds of learning. One method of learning or integration in clinical reasoning is experience, so experiential learning. So I have had a case, I was remembering this patient with urinary retention, although I don't think it's it's what's causing the issue here, but he had devastatingly terrible urinary retention due to BPH. He had probably about 1.5 liters of urine in his bladder, but he came in with the inability to walk. And what likely had happened, the bladder was so distended, it was possibly pressing on some of the nerves in the sacral plexus. So I was more considering a neurological cause or maybe a spinal cause, but then on doing imaging, I found a ginormous bladder, and then aggressively addressed it, and then he could move his legs. So interesting. But here, I think there's something more ominous at play here, and something that is possibly unfolding here is cord compression. And time is of the essence to get an MRI, because the longer we dwell on this, the more likely the patient could suffer permanent damage. So back to you, Mario. Do you have, like you had mentioned, that there was something else outside the bell that likely was causing it? So here we have unmask something that's happening and likely causing this presentation.
Yeah, so great discussion. This definitely caught us off guard. We got a stat MRI of the spine. I don't, if it's okay if I share it. Give me 1 second. Let's see. Can you see my image? So that was the MRI. I have two images more. This is the first one. This is the second one. In different MRI sequences.
Okay, well, what I do see there, definitely, if you look at the spinal cord and you see it's just following it down, you see it, the interface, you see this hyper intense line, and then the hypo intense line, and you see the complete obliteration in the middle with this sort of not a rectangular, but this circular mass, which is hypo intense. I think usually on MRIs we talk about intensity of signal, so it's a hypo intense signal. And then you also look at the vertebral disc here, and the vertebral body is collapsed. So it looks like whatever is causing the pathology is involving the disc, also involving the vertebral body and impinging on the spinal cord as well. So a lot of obliteration of the spinal cord architecture. And then if you follow down underneath that, you do see a hyper intense. Even you go 1, 2, 3 vertebral bodies below the one that's collapsed, you see this sort of mass lesion and a spot there. So there is a process at play here, which is involving multiple levels of the vertebral bodies, but there's severe distortion of the spinal cord architecture up near the collapsed vertebral body. So yeah, there's definitely something there, and namely, what could it be? Any ideas, Hans? You want to, while I was talking, are you thinking of anything that could be causing this?
Yes, looking at the vertebral bodies below the lesion and above, we can see those white spots, which are probably lesions from multiple myeloma. So I would guess it is related to a disease with the plasma cells acting up in her vertebral column and causing a vertebral body collapse with an injury of her spinal cord and all these autonomic manifestations, constipation, and now even urinary incontinence, as well as the paresthesias and a loss of motor function in her lower extremities.
I absolutely love that, and I will actually commit to your diagnosis there. I think you have it, and I doubt there's any spinal cord involvement with any infection. This does not have the appearance of a spinal epidural abscess, but definitely the past medical history there, namely multiple myeloma. We were trying to figure out how we could cause this, and we were thinking the electrolyte abnormalities, but now we went through the CRA. Now B is probably where it's at. So I'm going to send the mic back to Mario to see, is there one more aliquot, or is it time for the final DX?
So the next aliquot gives the diagnosis. So the patient was diagnosed with acute spinal compression and was rushed to the OR the neurosurgery team resected the mass. It was difficult to know if it was intrathecal, epidural. We weren't sure what anatomical error what this mass was, but it was resected. They stabilized the vertebrae, and the mass was sent to pathology. And 3 days later, I wish I had the pathology. I think I have lost it, but the slides, but it was compatible with plasmacytoma. So the final diagnosis was acute medullary compression syndrome from extramedullary plasmacytoma. I can tell you how this patient's course went, if you don't mind. So it was very unfortunate because this patient had evolved fairly well to the initial treatment, but presented an extremely rapid relapse. The patient didn't only have this one lesion. The patient developed a lesion on the back of the arm. He had bilateral pleural effusions associated with mediastinal masses that also were compatible with plasmacytomas. So an extremely aggressive extramedullary presentation of his multiple myeloma. He went extensive second-line chemotherapy treatment, and as you imagine, he got a lot of complications related to that. He had to spend a lot of time on ICU out of neutropenic fevers, and sadly, when I was finishing my internship, actually, I met this patient at the beginning of my internship. The patient sadly passed away from septic shock after an extensive chemotherapy. So a very sad case, but extremely, I learned a lot from this case. So yeah, that's all I have.
Thank you, Mario. That was an expertly presented case. I really appreciate with all the imaging. Imaging was great. I love trying to see the pathology and understand it rather than just you gave a great presentation with the words, and then the imaging augmented it. So it was very helpful. Very unfortunate to hear the patient had passed away. So I really am thankful for to the patient for allowing us to learn about this condition and to make us better physicians and better equipped to make a diagnosis in other patients that may come through the doors of our institution. So I'm very thankful to the patient, and very unfortunate that the patient had passed away. And I'm very happy to discuss with Hans, and it was really helpful listening to you, and then also that triggering a lot of thoughts and helped me in my clinical reasoning. So any reflections, Hans, about this case? It was very interesting that, we think about constipation, immediately my mind is thinking about bowels and bowel disturbance, but it was outside the bowel. So definitely a very high yield case, and lots to learn from this case.
Yes, it's I've learned really a lot from this case. I don't even know how to say thank you to Marion for presenting this interesting case. It's unfortunately very sad. Extramedullary plasmacytoma is very rare, and it's extremely hard to treat. That's what I know. And now I'm thinking much wider about constipation, and I've always taken it very serious because there is something going on, and psychiatry is just something to be ruled out. But that was just an humbling, big learning case, and I'm going to reflect over it.
Oh, definitely. Mario, anything you learned specifically from the case? Yeah,
so I think we all try to figure out how could we have caught this earlier, and I think actually I don't think we could before the other manifestations other than the constipation. I think it was extremely hard because the constipation and the paresthesias are things that are very common in patients that have taken the VRD cycle. Bortezomib is very, very, very associated with peripheral neuropathy. So I think it was, I'm not sure if maybe the constipation with which the patient came in was just his normal constipation, and maybe this acuity really happened in these days. I'm in those short days. So I'm still not sure exactly how this developed, but for me, at least, the teaching point was to be able to recognize acute medullary compression and to know how to act. You have to start steroids right immediately, and you have to call the neurosurgeons as fast as possible, because it's an emergency, not because the patient will die at that moment, but you can save this patient's ability to walk and to urinate and to have a better quality of life. So yeah, it was a great case, and I'm glad to be able to share it with you.
Absolutely important point there. So this is something I've dealt with, and is, like Mario said, is very important to remember to get early consultation with neurosurgery, because the patient could end up having permanent inability to ambulate. And great to see you on again, Mario, for bringing this case. And we have another person, Promise, who hasn't been on for a while, but also great to see again. And you're gonna take us on with the teaching points. Promise.
Yeah, thank you for this wonderful case, Mario. It's so nice to see you again. This is definitely a very sad but also very humbling case. I think we started out with constipation thinking more of the common causes of constipation, you know, like in the bowel, like it could be IBS, IBD, could be diet, where we thought about like very common like electrolyte abnormalities or some sort of autonomic dysfunction or obstruction or medication. And we kind of like started out really broad, but with this patient having a history of multiple myeloma, has been on chemo, kind of added some layers to this case. And I think that both Ravi and Hans did a really good job remembering these background things that could come into play, and then kind of teasing apart the problems that are showing up, especially with having like newer problems like paresthesia in bilateral lower extremity that we weren't really kind of expecting if we're thinking about a intestinal cause of abdominal pain with some constipation. And I think that we kind of made some progress when we learned that this patient was unable to pass gas, and then we saw the x-ray imaging and we saw that there was obstruction in the bowel, and then realizing, okay, this might be something going on, and is this something emergency that we have to consult for a surgical abdomen right away? And then this patient ended up developing these neurologic symptoms that really point to a spinal cord compression, and then doing an MRI in the spine, and then consulting neurosurgery immediately to see that there's a vertebral collapse, and then they also find a mass which end up being the extramedullary plasmacytoma, which is something that I've like heard of once, and then now I definitely have to read up more, and also learning about the management, like how we would, in this case, like treating and managing is more important than like diagnosing right away. Like we have to treat with steroids and consulting neurosurgery to make sure you know, it doesn't cause permanent damage to the spinal cord. But yeah, this really wonderful job. It's very humbling and also very educational to learn with everyone here. Thank you so much for such a great case, and I hope everyone has a good rest of their Tuesday afternoon or wherever you are.
Thank you, Promise. Great to see you on again, and thank you for the great and superb teaching points, and especially putting them in highlight there so we do remember them. So thank you, everybody, for coming on, and thank you again, Mario, for the case, and thank you to the patient. And take care. See you tomorrow. Bye.